think we'll make it start. So it's just 10:04. It's great to see everyone, by the way. So I've started recording, Val. So just if you're wondering, so that's done. So hi everyone, thank you for joining us, and great to see you all. It's fantastic to see so many faces today. Good to see you all. So we've got a really good session planned today with lots of fantastic speakers and our sponsors. So I'm really looking forward to it. There's some housekeeping things I just need to go over, the boring bits. Let's get that out of the way. So if you want to chat, I can see that you're already chatting on the chat function. So if you have any question, please write there, Val and others. I've just pressed, thank you, thanks. I've just pressed recording and it's recording now. And you've used Zoom for so many months now, so you know that you could change the speaker view to look at and change the views to whatever kind of suits you. So just some updates from us. So as you know that we were recruiting to our AphA board, so we now have the full board recruitments completed. So the last two to join our board, I'm really pleased to say, it's Julia Wilkins, so she is joining as our Director of Region, and we have Andy Orlowski. Andy is joining us for our non-exec director on our board. He will be leading the collaboration and clinical engagement. So great to have both of you on our board.
And ironing.
Ironing, yeah, the high wattage iron. Thank you. And you've probably seen an email gone out from Val before. So we're really encouraging our members, and if you're listening or if you will be listening, to join our board meeting. So for going forward, every month we will create a section for you to come in and share your ideas, just have a conversation with us if you would like us to do anything. It is our organization, so we need to work together. And we will be listening to you and really try to do what you would like us to do together. So I'll really welcome, if you can, I know you're busy, to attend our board meetings if possible. And thanks to Ideal Health, Catherine Smith, for sponsoring this event. I know we'll be hearing from Ideal Health shortly. But first, I think if I can get the agenda, I'm looking forward to this session. So we have Laurie. So Laurie Suarez, so she's from Nottinghamshire Healthcare NHS Trust. And Laurie is also our AphA Analyst of the Year. So Laurie will show us and share with us some of her work, which I'm really excited about. So Laurie, welcome.
Hi everyone. So I am going to be talking about the project that linked to the awards. So I'm hopefully going to spend 5 minutes on what led up to the awards and actually what I've done with it since. I'm really lucky with this team. They're all very innovative and they put up with me, and to be honest, that's half of the battle with the clinical teams. So if I just share my screen to get I managed to avoid it, so bear with. Go up at the top. Here we go. So primary care psychological medicine, which is a novel service, which is my name, and that is my Twitter handle. I have to run away not long after this to go to the hospital. So if any of you've got any questions that I don't get a chance to answer, please feel free to message me on Twitter. I will be all over excited. So just as a bit of a background, PCPM started seeing patients back in 2017, and it's a specialist service that brought it into primary care settings and into patients' homes, which for a service that's bordering on this is very, very unusual. This sort of service doesn't exist anywhere. So we didn't have any proper models from a clinical point of view, but also when it came to the data, I had no one else that had ever had to prove this kind of model. So it was a bit of free rein, but it was quite daunting. And this is a specialist for patients with medically unexplained symptoms, also known as psychosomatic conditions or somatoform, where a patient is experiencing real symptoms, but it tends to come from a place of anxiety or depression. And it's surprisingly common. A lot of people know they get stress headaches or stress tummy aches, but it can get much more serious to the point of people not being able to move limbs. But also people with chronic illnesses who's affecting their life that badly, and it's had such a toll on their mental health that they are unable to partake in a lot of situations. So I said there was no general standard or knowledge of the impact to really be able to prove this service well. So we had to start from the very bottom. So we first had to look at where could the impact of this be measured? Where were these patients interacting with the system? for us to be able to see both financially, because that was a big drive from the commissioners, but also were the patients actually getting better? Money saving or not, did the patients appreciate the service? So we had what was within the team and within the mental health service, but these patients also interacted with secondary care, such as inpatient, outpatient, and ED. There was EMAS, because for the local, that's the ambulance service near us, they would be taking patients to and from ED, and a patient going by ambulance has got different costs and also a different stress level. If you're poorly enough to need an ambulance, that's quite a different thing to being able to take yourself to ED. They would be cropping up in primary care. There was also things like a lot of these patients claimed benefits, and a lot of them did want to be working, they just did not feel well enough, which obviously has a financial impact and a social impact. And also prescribing, there was a lot of medication going on for these patients. And again, as the patients got better and needed less medication, that's better for them because you've got fewer side effects. Fewer meds to remember is fewer meds to forget. But there's also a cost in prescribing, even with the contributions. There was also other considerations that had to be made. We found a lot of this data. The primary data we had was our team, secondary care and EMAS. Primary care, government and prescribing, that data unfortunately didn't exist, but we could talk about anecdotally. We had lots of GPs on board that would tell us actually that things increased. Patients were seeing primary care more. And that's not necessarily a bad thing, because a primary care appointment is less stressful, better for the patient than attending gastroenterology or neurology at the hospital. So that spike was actually a good thing because it was shifting it. This was never going to just suddenly disappear overnight. We had then lots of considerations. It wasn't just straightforward, this is what they were before, during, after. There was a lot more. There were unavoidable events. There was one patient who'd been told that their conditions were all psychological. And about 3 months after we got involved, it turns out the patient actually had stage 4 cancer. Very different remit, not really our thing. So I sat down with a consultant. We looked at where the numbers seemed unusual. And we went through them. We kept some and we had to exclude others. We also excluded pregnancy because as anyone that's had a baby knows, you tend to have an increase in hospital appointments. And so that wasn't going to be a true reflection of the teams. We'd really hoped that someone had got pregnant before and after, but so far, and apparently you're not allowed to encourage that. So that was a bit interesting. We had to look at appointment booking. If anyone's ever been open to a secondary care outpatient, you know that you attend the appointment today, and then they'll go, I will follow you up in 3 months. So although that contact and the money occurs in 3 months' time, which would be February now, I think that's 3 months, the booking and the decision for that appointment happened now. So when you're looking at when the costs were actually incurred, we had to put a time lag on it, and the same for elective procedures. So again, when you have a surgery that isn't like, you turn up to A&E because your appendix is about to burst, but it's a planned procedure like a knee hip operation or a planned investigation, again, you've got this time lag. It's marked as being in January, but that it was never booked on the 12th of January, it was booked in advance. So again, we had to look at and try and account for this to show where the spikes truly were and where the patient demand actually was. The other bit that got interesting was that the financial data just disappeared about halfway through the project. They sent us one load of data that had all the information. Knows block contracts are very confusing because it will show up as £0, which is true, but it isn't true because you have the block contract expense there. And the more people that need to use a block contract, the more you pay for the block contract. So maternity is often block contract and a few other different services. A lot of mental health services end up being block contract. And again, when we refreshed the data, all the financial information disappeared. So we were left going, the financial is really important, especially in the world of commissioning. They want to know money. They do want to know a bit about the patients, but you win half your argument with money. So the best we could do was we looked at the average cost of an inpatient, ED and outpatient attendance before, during and after, and then just replicated it across the service. And it's not the best thing because the true financial data would have been more useful. But actually, even in the averages, we saw there was a distinct change, which again is important because some outpatient departments are more expensive to run than others, and they are more taxing. So again, that was quite important to everyone. We also had to include patient disengagement. So if a patient attends twice and goes, nope, your service isn't for me, we had to consider, did we have an impact on this patient? Because they wanted to see the patients who had an impact on what happened. But there's no clear-cut way, because just getting a referral to a team doesn't mean you get the benefits of the team. But we also had to be fair in sort of going, well, what does count and what doesn't count? So based on some knowledge of psychosomatic conditions and the treatments for them, and also looking at our data and all the anecdotal information from the nurses and doctors, we realised that after 3 appointments, even if the patient didn't get their full treatment, they did get a benefit. And this actually was reflected in the data that within 3 appointments, patients did start to improve. So we had to set this disengagement point. And then that was also led us to what are other influences in this, and also service equity. Why were patients disengaging? Was it just that this didn't feel right for them? Because it is quite hard to hear that you have physical symptoms and people go, oh no, it's psychological, go and seek psychiatric care, because there's still a lot of misunderstanding as to what psychiatric care includes. And I think people can still panic and think about some of the old ECT type things when there is so much more to it. So we did a full thing on service equity to look at what was different between the patients that did engage and didn't engage. And the main thing we found was the patients that lived further away from the GP practice were less likely to engage. But there's a logic to that. If you are very poorly and you're struggling to get out of the house for anything, driving 30 minutes for an appointment, if it's not immediately selling you as being beneficial, you're less likely to do than if you're only going to have to travel 5. It's what the patient has to put in. So can't really blame them. And then the commissioners wanted this. So I've got all this data from all these different places, all this consideration, and they just wanted a graph. And it's kind of heartbreaking. I'm sure most of you have experienced this when you've put blood, sweat and tears and hours and hours and hours of work into looking at the data and understanding it and making sure you've got the right people to get this one little 3-line graph. But had we not done that, and had we kept in some of those outliers, like the cancer patient thereafter was massively, it was much, much bigger than everyone else. Everyone else was averaging about £15 a month. And theirs, as you would expect for something like cancer treatment, was at 400. So even in a big cohort of 200 patients, it would have still been bonkers. And the same as some of the before, there was one patient who actually 2 years before coming to us had been in an RTC. So again, they had massive costs. They'd broken their spine in 4 different places. It's expensive to treat. So again, we didn't want to use it to sell ourselves better, because we all strive on working honestly. And so it involved splitting all these things out. So although it was painful and had all that data, it had been quite easy to do something really complicated with this complicated set of data. But it had gone straight over the people who make the decisions head. So it's when you kind of have to bite the bullet and go for something really simple. Although it doesn't always feel like it's doing you justice, actually, what goes on behind it really did. And actually, you can have so much confidence in something like this. And we did manage to explain why the outpatient thing increased. Some of it was still the lag. But also people were getting poorlier and poorlier and poorlier. And that's not to say that they weren't symptomatic anymore. It's just that people could manage their symptoms better. So there was that spike when patients were being discharged from outpatients and all this with the increase. But as you can see, after their treatment, it definitely came down. The main issue we had was integrating the PROMs. So PROMs are patient-reported outcome measures. Please don't shoot me, anyone, but when I first started, they were using SPSS as a database. And it didn't even have dates in it. They were just recording numbers and running away, and it was horrible. And I cried. It was horrible. But this involved a lot of paper, because someone would have to write it. Like the patient would write on it and give it to the clinician that would give it to admin that would eventually type it up, and there was all this transcription. And it was, yeah. So I wanted it on the electronic patient record. It just made so much sense. The clinicians could see it better. It cut out a lot of the middleman and everything. And it worked, and we eventually got there. But we had the issue. I now had this horrible SPSS database that unfortunately had been going for 3 years before I'd managed to get in, because I'd been using it in the pre-pilot project as well as when it became official in 2017, and the current data. So what I did with the old data was I just focused on first and last PROMs. I didn't have the dates. I had a referral and discharge date. We had to just focus on initial and discharge dates to get the PROMs. So there are some databases and data collection you can fix a little bit. Obviously, it was a shame because one patient had 14 PROMs that we had to delete 12 of them. But at least that start and end could give us still the accurate change throughout. But then the clinicians had to know. So at least when admin were doing it, admin could go back and go, oi, where are your PROMs? Why haven't you given me anything? What is going on? When it became more clinical, admin didn't have that anymore. There was no oversight for the managers and no one really knew what they were doing. And some of the nurses were great at this, and other nurses had no clue how often they were doing them, who had them due, anything like that. Which is a bit of a problem because it's still so important. As it's still a very novel service, we are constantly having to fight to keep our funding. It doesn't matter how often we prove that it's a great service and the patients love us, we still have to keep fighting and fighting and fighting. And now that we've proved the finances to the nth degree, they want to focus on the patients. So I had to build something to help them, to give the power back to the clinicians, because they are a very inquisitive team, but they don't want to have to wait for me to tell them what they're doing. So I built a dashboard and I have mushed the patient information so it's not identifiable, nobody panic. So we've got this dashboard. So that the main thing I wanted to keep this at the top is that the clinicians can see the amazing job they're doing. We've been so worn down by having to fight and have so many commissioners doubt us and go, is it really worthwhile your service? Are you really doing enough for these patients? When the clinicians are, it was heartbreaking and it was really, really affecting morale. So I've always kept this at the top because it shows them that they are doing a good job and they know they're doing a good job, and I can remind them of it every time they open it. So these are the traditional prompts that you will have all seen before, and then these are the ones that we made up specific to our service because we realised that patients weren't leaving the house and now they were, but we didn't have a way to evidence it. So we collected something on employment and something on patients leaving the house. They wanted some box plots to understand each area, but this bottom bit is the main thing. This is a list of all the patients. As you can see, it's all mushed. I had to add the colours back in because I got a very upset phone call from a clinician going, where'd you put my colours? I need the colours to know what's happening. But it's fine, I like him, I sorted him out. And it worked. Again, this was all about making it work for the clinicians. If they wanted colours, they can have colours. When this doesn't look like gobbledygook, the clinicians can find their name. So I'm hoping I've got one copied. So within Care Coordinator, they can type their number. I don't know, let's call this person Adam. I don't know which clinician it is. They can now see where all their patients are. So they've got quite a few overdue. These are the ones that are due soon. These are the ones that are complete. And once they understood what this meant, because I discussed this on Twitter a little while ago, some of you may have seen, in data, a month is very different to a real month. We say a month. So if you ask a clinician what happened last month, they will talk to you about October. In data, a month is the last 30 days. And it caused a lot of issues because it meant that their 3 months ago wasn't the same as my 3 months ago. But again, that clinical understanding and engagement really understood it. And the best bit that happens is if you click CSV, and I've prepared this earlier so it would be quick, it downloads it as a CSV file. So this staff member can now see everything they've got going on. They can see the status, they can see the client ID and the patient name, because they said they responded best to patient names, where they're, the area they're from, and then the date. So a couple of these patients have got appointments today. So hopefully tomorrow, these won't show as overdue anymore. I'm not holding my breath, but it gives them the opportunity to see that this patient, this patient, this patient, and this one who are all overdue are being seen today. And thus in their appointment today need to be pestered to get some proms out. And it's worked really well. The accordance with proms is great because when we first started, out of the 200 patients on the caseload, 150 were overdue for their proms. And now that number is down to about 50, which given that you don't see patients reliably every 3 months has worked out really well. But it was a lot of toing and froing, but now the team are fairly self-sufficient, which is what we want. We want the teams to be curious about their data. We want them to be able to see their data and take it from there. So yes, this was a very intense few weeks, but I mean, I speak to the team because they're nice human beings, but I've not touched this in 5 months, 6 months, because it's just how they need it. They don't need to pester me for the information. They can have it whenever they want. And we know that clinicians are busy human beings, so the quicker they can see it and move on, the better. By the time they've got to start sending emails, they lose time and interest, unfortunately. But yeah, I think that's everything. I think I'm also over time, so I apologise.
No, that's absolutely fine, Laurie. Really interesting. Thank you. Thank you for presenting. That's really, really interesting and useful. If you have any question, please do write the comment. I'm sure, Laurie, you're probably staying with us, so you might be able to. You've got to run.
I've got to run now because I've got an appointment.
Okay.
But I'll try and come back at the end because I know we've got a little bit of wiggle room.
Yeah.
But if not, my Twitter handle was on the thing, I'll send it in the chat. I can't see the chat because I'm on the VPN stupidly. But if not, Zoe, who I realise I'm doing this because she's next to me on the screen, but she may not be on anyone else's. Zoe's on my team. If any of you can't find my Twitter handle,
thank you very much.
I'll put you in touch and hope someone can see it. But yeah, I'll try and come back later. But thanks, everyone.
Thanks, Laurie. Thanks. That was great.